Hi, welcome to October's Black Health Now event. My name is Brenda Ask, Chief Strategy Officer at Biolumina, Omnicom Health Group's anti-cancer agency. And today we'll be discussing the disparities in cancer outcomes within the Black community and what we can do to help make meaningful and impactful changes. And we're so honored, we're so excited to be talking with Dr. Tania Small today. Thank you so much for joining and speaking with us. By way of introduction, would you like to tell us a little bit more about your background?
Sure, thanks, Brenda. So I'm Tania Small. I am a pediatric hematologist oncologist. I left academia over a decade ago, and I left because I was tired of not having all the tools in my toolbox to save my patients. Um, and I look at the progress of medicine over the last decade plus, over the last few decades, and we have made just incredible strides. There's been a lot of work, and people are living and thriving, but it's still not enough. And when you look at the numbers, and we'll talk about that today, the rate of progress has not been the same and equal for all. And so this is why to me this conversation is so important. So thank you for having me, and I'm looking forward to this discussion.
Yeah, I think there are some statistics that cancer survival has increased by 25 or 30% since 1991. But you're right. You shared this really impactful slide with us, which I'll bring up now, that shows it's not the same across audience. There's still a lot of work we have to do.
Yeah. And I mean, again, when you look at this slide, I mean, the numbers do not lie. And it's really bothersome that we have to look at these stats. When you look at this, you see there is a big discrepancy when it comes to outcomes based on race and ethnicity, and this is what we need to pay attention to. So if you look here, cervical cancer, Black women are less likely to live 5 years after being diagnosed compared to their white counterpart. Multiple myeloma, African Americans are 2 times more likely to die from this disease. Breast cancer, women are have that Black women have the highest rate of breast cancer deaths. When you look at endometrial cancer, again, nearly twice the risk of dying. Prostate cancer, twice as high in terms of death rates. Those numbers are not acceptable, because how can race or ethnicity be the reason that a patient lives or dies? And that is not acceptable to me. This is more than just numbers. This is a true healthcare crisis that we have to address.
It is such a crisis, and this bottom line is so important that people are dying because they don't have access to and aren't receiving equitable care. Why? What are the reasons behind that?
I mean, and I think this is where the topic is going to get very interesting for the next hour, because a lot of times we hear people talk about there's a big trust issue in the Black community, and that is why they're not getting adequate healthcare. There's a big trust issue in the Black community, and that is why they're not getting access to clinical trials. And what I want to do is really, yes, I want to respect that. I want to acknowledge it, because historically, there has been systemic racism that have prevented Blacks and other people of color from getting good treatment, and actually that's been hindering the treatment of this race. However, it's way more than that. It is multifactorial. And when you just focus on a trust issue, you end up blaming the victim and you stop progressing. So what I wanted to do is, yes, we're going to address the challenge of trust, and we're going to talk about ways in which we can start eroding that mistrust. But I also want to talk about true, tangible barriers that we can address and action to remove. So I'm really looking forward to this conversation today.
Yeah, me too. There's so much more that we can actually take action on and make an impact.
Yes. Let me just kind of highlight the 3 areas that we were really talking about. So going back to your discussion on trust, just to recap for those that just joined us, one of the things that I really want to highlight is, yes, there is true distrust based on just systematic and historical racism, right? I mean, has plagued us for centuries within this country, within the world. And so that is a real challenge. And there's a lot that continues to happen to erode the trust within different patient populations and different ethnicity and race and races. However, And this is the thing that I want to make sure I make very clear. That blames the victim. That blames, if we just say it's a trust issue, it allows us, it's a dead end when it comes to solutions. Because now we say they don't trust us, so we don't move forward. And we know that a lot of the recent data has shown that that is not the number one reason why patients, well, actually Black patients are not coming on trials. And so for those who missed it, I mean, I went through, there was a study that actually ASCO presented in people with breast cancer. And about, I think about 102 patients were Black that had breast cancer. When they were asked, would they participate in a clinical trial, 83% of them said yes, they would participate in a clinical trial. 40% of them said they were never offered, or the clinical trial was never even discussed with them. So almost half of them didn't even hear about a clinical trial. So it wasn't that it was a trust issue, it was actually they were never offered. I also quoted the multiple myeloma study where the FDA released this information on patients. I think they looked at all the studies that registrational studies that came to them between 2006 and I think around 2017, around there. And we know that 22% of those diagnosed with multiple myeloma are people of African descent. However, out of those screened for potentially coming on the trial, only 4% of them were people of African descent, yet 84% of them were white. And so that already shows you, that alone shows you the bias that's happening where patients are not getting offered these clinical trials or even discuss clinical trials based on their color and based on their ethnicity. So that alone shows you that it is not a trust issue that is stopping them. One of the biggest issues is institutional provider biases. We come in to our occupation, we come in to treatment with our own lens, with our own biases, and all of us have it. And what we have to do is now come up with solutions to override those biases to make sure that we make it more equitable. So that's one big area I think that we have not discussed and we don't talk about a lot. But what can we do to override the institutional and physician biases to make sure that people have equitable access to these trials and to actually just healthcare? The other piece that I think is really important for us to address is just the clinical trial itself. Creating more inclusively designed clinical trials are going to be really important. When you look at eligibility criteria, we know that they're not, that we've used, first of all, as a baseline lab, usually white males are your baseline lab. And we know that biology is different. A lot of it, even based on ethnicity and race, there's different biology. A good example is a prostate study. You use a baseline a lot of times of white males where you know people of African descent may have different testosterone levels. And so a lot of them are ineligible. Or we also know that a lot of people that people of African descent just in general tend to have lower white counts and lower hemoglobin counts. Yet the baseline is based on, again, white males or females. And so a lot of times people of African descent get excluded because our baseline level tends to be based on people who are not like them and who may have different baseline levels. Also, another thing for eligibility criteria, comorbidity. They're different in different communities. And so a lot of times patients are excluded based on comorbidity issues. Other issues in terms of exclusion criteria, and one particular one I'm thinking about is multiple myeloma. A lot of times your eligibility criteria is based on the previous treatments that you have or received. If in your community you're not getting the most innovative therapies, a lot of times it knocks you out of the eligibility criteria of the new medicine. So again, there's so many things just in the study design of a trial. Then the other piece is, then let's talk about the practical community piece of these studies, where consent forms are not at the right educational level. Consent forms are not based on cultural sensitivities. Another piece is translational services. If English is not your primary language and yet your physician is only speaking to you in English, then there's a lot that you may not understand. And coming from, again, Washington Heights, where I used to practice, 50% of them spoke Spanish. So how can I relay the details of a trial in a language that's not their native language and get them to understand the complexity of it. So to me, just having more inclusive trial design is another thing. So you have physician bias and institutional biases. You have inclusive trial design. And then the other challenge to me when it comes to barriers are just social economic barriers. The majority of these studies are offered in academic institutions that do not cater to the communities where a lot of these patients are. And patients don't wake up saying, I'm going to get diagnosed with cancer today, so let me get my life together. Cancer is a diagnosis of surprise, and it's one of the most awful diagnoses. And I'm sure all of us can say we know someone who's either been diagnosed or even passed from cancer. The amount of the, the emotional challenge that it puts into our lives, the day-to-day physical challenge it does. I mean, just the things that you have to put in place because you know your life has changed from the time you've been diagnosed. And then asking this person to travel miles to get to sites that are that run these clinical trials. Sometimes impossible. A lot of people have work, they have families, they have other day-to-day stuff. So one of the challenges, the trials are not in their community. The trials are not being offered by their physicians because we tend to run trials with the same physicians over and over again. So we're not even getting it into the communities. We're not offering it to new investigators. And then the other thing is the cost. Insurance, some insurance companies do not cover the requirements of clinical trials. And then how do you pay to get from one part of town to the other? So there's just so many social economic factors, clinician bias, and to me, inclusive trial design. And we pull it all together. That trumps trust any day of the week, because those are tangible barriers that we can do something about if we focused on it and not just blame the victims.
Absolutely. That is such a huge disconnect when statistically you have worse outcomes or more aggressive diseases. You have a higher prevalence in some parts of the community. And these trials, the institution, it's not designed to support optimal care. I know there's so much we can do, so much we can action on. The one thing that speaks to me and probably all of us who are working in communications is how do we what can we do to support better care, to support that shared decision making between a physician and a patient, or communicate the benefits of a treatment more clearly.
Yeah, I mean, I think maybe if you can pull up this slide that actually shows, like, to me, the different solutions. So right now, hopefully I outlined, I mean, again, there's so much, right? It's multifactorial. There's a lot of things we could talk about, but to me, if we can focus on certain things that's tangible, um, then I think it's just, yeah, there it goes. Then after that, I can talk to me, then we could dive into just from a communication standpoint, because I think out of each one of those, there's a lot that can be done. So, like I said, if we think about inclusive trial design, institutional and provider biases, and community and social economic burden, these are the things to me that we can start doing tangibly. And then within those, from a communication standpoint, you can really dial it up to help make this big difference. So if I look at inclusive trial design, I spoke about the eligibility criteria. How do we make it more inclusive? How do we take a step back and look at all the protocols that we have and see what's needed and what's not needed? And then how do we, right? So making the eligibility criteria more inclusive, how do we make sure that our baseline characteristics really match the patient population that actually has the disease? Then if we think about even the trial material, back to your communication piece, trial material, how do we make sure that the trial material is written in a way that patients understand it? It's written in a way that actually is really transparent and they can action certain things. A good example is how do we make sure that it's in layman? So when people are looking at side effect profiles, they know what to expect and they know what to do about it, so that they're not caught off by surprise. To me, those are things from a communication standpoint, we can make a big difference. Consent forms. How do we make sure the consent forms are appropriate? We can actually do digital consent forms so that as a physician is explaining it to the patient gets to go home and discuss it with his or her family and then make a decision, a collective decision based on what that family wants to do, and then accept digitally. There are things that we can do to change the way we're doing it. Again, being more patient focused, making the trials less burdensome. They shouldn't have to come back and forth. I mean, I look at some of our phase 1 trials. I don't know if I'd be able to do that. Coming in 3 days a week to draw labs, and we can actually make it less burdensome. So, how do we even pull the patient's voice into looking at the trial design to make sure we're taking a patient perspective? And again, making sure that the study design represents the patients that actually have the disease. Translational services. How do we make sure that the material that actually we have translational services, whether we can call them or have someone there, depending on your community, and make sure that our material comes in more than one language than English. So based on where the trial is being offered, we should know the population that lives there. So to me, from a comm standpoint, there's a lot that's in there that we can do. And then from an institutional and provider bias, I mean, we cannot change the way people think, but what we can do is educate them. So to me, anyone who's running a trial, and this is what we did in GSK, anyone who's running a trial, you're going to have to take some type of cultural sensitive trial design, trial training, because we need to make sure that you are culturally intelligent and really doing what's on the patient, what's right for the patient. So making sure that we mandate that if you say that you're going to offer this study to diverse patients and you're going to have a certain number, make sure that we're going to make sure that you're actually delivering on that. I've had a colleague that actually stopped, didn't close out a trial because she did not have the right amount of diverse patients on it. Those patients did not represent the people who had the disease, and she made the trial go on longer. And actually, which is pretty impressive, those physicians that committed to recruiting diverse patients, she held them to it. And so I think we need to make sure that we hold that down, and we really develop a hard stance. Like I said, definitely those training, deploy diverse equity and inclusion training programs for PI. So in case, I mean, we may be able to show them just how to communicate with patients. Why is it important? There's studies that show that patients obviously trust the physicians that they go to. And part of the challenge is that physicians, the referral process, physicians that actually are treating these patients in underserved communities are not being offered clinical trials for their patients. They're not being chosen as the PI. So we need to increase the pipeline of diverse PIs. We need to mentor them, we need to train them, and we need to invest in their community to create sustainable solutions in their community so that they can offer clinical trials to their patients. And again, like I said, making sure that the material represent the patients that actually have the disease. So that's, to me, the institutional piece. And then if you move to the community and access piece, just as academic institutions we have to invest in creating these community-based sustainable infrastructure. We have to do it. Because you cannot expect a patient to leave their community to go to a different community. So how do we invest in their communities? How do we do more virtual labs? How do we do more virtual screenings? How do we invest in an infrastructure to allow them to stay in their own community and participate in a clinical trial? We can open up more satellite sites and more telehealth sites. The other thing is, again, as I mentioned before, people are people with their daily lives. Can we find a way to compensate them or even reimburse them, which is allowed if they're participating in a clinical trial, for things like transportation, for just things for hotel stay when they have to spend the night there. So there's so many things that we can do to reimburse their costs so that cost is not a factor for them to participate in clinical trials. And the other piece that I'm thinking about is also trust. I mean, like I said, I don't dismiss and I don't want to negate there is a trust issue. But there's a lot that we can do to alleviate a lot of it. Besides the three that I talked about, the three categories, really making sure we're transparent. I think being transparent on the data, being transparent on the outcomes, being transparent on the side effect profile, being transparent on the number of patients that are being offered the trial is going to be really important. Making sure patients get access to the data. And again, invest in insights in their own community, because we know that patients trust the physicians that they go to. And then also partnering with the communities. People trust their community. How can we in the industry partner better with the communities? Patient advocacy groups, with churches, barbershop, beauty parlors, whatever, wherever people go, whatever their trust circle is, how do we partner with them? But because again, this again is a healthcare crisis, and we need to do much more about it.
I like the two things that stand out, particularly as things that we can action upon. One is the tracking, like making sure that we have the right investigators and the right sites and the right number of people. I like that if it's off track to stop it and realign, but also the transparency. I feel like in oncology, we are in an alphabet soup of OS, PFS, response rate, and it's so overwhelming. Like, what does this all mean? So we talk about grade 4, or grade 2 diarrhea. What does
Yeah.
that mean? And putting it into a human language is so important.
Yeah, I think there's two pieces to what you're saying too. I think, how do we make people understand what that means? To your point, grade 2 protracted nausea is not just a number on a page. It's horrible. Being nauseated the whole time, that is a problem. And how do we make sure that or grade 2 diarrhea? I mean, just showing a patient that does not mean that they understand what that is. Or fatigue, or then we started using all kinds of words that people don't understand. How do we make sure that they know what to expect, so that they don't think that it's them, or they don't think that it's the disease coming back? They understand that this is what can happen with this medicine. It is not you. It is the treatment that we're giving you. And these are the things that you can do to help alleviate it. So just being very transparent and taking the time to explain to them what this means, to me, goes a long way. And that to me is what we talk about, patient driven science. To me, that's what that is. It is making sure that the patients are driving your language and your science. Um, the other pieces, I think, from then a drug development standpoint, a lot of times we call things paper lab versus like symptomatic side effect profiles, but there's so much we can do to add more supportive care to these therapies. Going back to grade 2 nausea is not fun. We should be thinking up front. If we know that our drugs cause these side effects, we should be thinking about the supportive care required to alleviate that as much as possible. So I think being very transparent with what to expect, so that people really understand, but also developing the right tools, solutions, and support to help them get through it. To me, is what we need to do better when it comes to thinking about the patient versus just the drug and the disease.
Yeah, I think as we get more and more developments, more and more advances in targeted therapies and immunotherapies, there's more opportunity, and also to incorporate an understanding of the patient voice and their choice, and to empower patients to co-create their disease journey and their track with a physician.
Yeah. I mean, I think what you're saying is so important, because patients are people, and we're heterogeneous. We may want different outcomes. Some people want you to hit that disease hard no matter how they feel. We need to understand that, and develop the right solutions for those people diagnosed with that disease. Some patients just say, you know what, I want to thrive and live my best life. And it's not about just giving me 4 more months or 6 more months, but while I am alive, I want to live my best life. And that means they may require a different treatment journey. And so it's so important to bring diverse patients to the table, to understand the spectrum of needs and wants, so we can develop the right medicines for the heterogeneous population, and make sure we're developing the right tools, the right educational tools, and the right treatment journey for them.
Right, absolutely. Uh, when there are there are a lot of ways we can address clinical trials, but more with regard to support while patients are on therapy, and particularly in the communication space, what innovations have you seen recently that will help stay on therapy, help with the confidence on therapy, um, and and ensure that those optimal outcomes are achieved?
So there's quite a bit. I mean, so if you're thinking about staying, so we'll remove the barrier of not being able to be offered it. So once people are on clinical trials, I think a lot of it has to do with just if you think about logistical piece, right? Just making sure that we remove their logistical barriers as much as possible. That sets them up for success. The other piece I think, as you were talking about, is adherence or compliance to the treatment. As I mentioned before, I think this is where comms is so important, communicating what to expect. I've had situations where we created like digital, I guess it's like a digital folder, digital file where patients themselves were talking about this is what you can expect. This is how I felt when I was on this. This is what I did. And obviously it was all approved, but it was this is what you can expect. This is what that feels like. And we actually had diverse patients doing it so that every patient that received it actually saw themselves being represented in that trial. So number one, empower them to know that that trial, yes, I deserve to be on that trial. I deserve to get the most innovative therapies. I deserve this. And it's not just for one group of people, it's for all of us. So I think number one, seeing diverse patients, making sure your material is inclusive. That I cannot emphasize it enough, because when someone sees a trial, you want to make sure that they see themselves in that trial. The second piece was being as transparent about what to expect. I've seen that again. We had diverse patients talk about what to expect. That allowed them to relate to it. That allowed them again to understand that, okay, this is what I know may happen. So I'm preparing myself for it. When this happened, I'm not surprised. I know that I should stay on a drug because over time it went away. So those are the things that I've seen make a huge difference in terms of um, of trial adherence. And then the third piece, we developed once an app that actually went to ASCO, that was all about just management, symptomatic management. And it was as simple as the ABCs. If a patient has this, then make sure you support them with this. And really thinking about the patient's toxicity. To me, if you're on a treatment, how can I make it less as how can I diminish your side effects that you feel as much as possible? So it was really about making sure we upped and ramped up our supportive care. And that again is another material piece, making sure physicians know if a patient says they have this particular side effect, quickly implement this or get ahead of the disease or get ahead of the side effect so that they're not feeling it as much and being mindful of that. And that is important. Um, Getting symptoms is one of the things that will stop a patient from taking the medicine. So stay ahead of it and make sure we're implementing as much supportive care as possible. So I think in when I think through a calm standpoint, creating the right material that does that for physicians, quickly teaching them how to manage it. Like I said, we created this digital app that did it. So the physician is able just to put in the side effect and up popped how to manage it, which made their lives a lot easier. The other piece, like I said, is making sure the patients are well aware of what to expect in a way that they can understand and relate to it. And then the last piece is making sure we remove their logistical barriers as much as possible to make it easier for them.
That app sounds amazing. Just thinking about how overwhelming cancer is and the experience, it's isolating. It's isolating and it's frightening for everyone. But to know that you're not alone, and to know what to expect and to know what to do, that gives you power over the disease.
Yeah, and I think that's so important. And one of the big pushes we have is making sure patients feel empowered to own their health and to collaborate with physicians so that it's a joint decision. Um, and so how do we empower them? To me, it's through a lot of education. And so you have even partnering them with people who may have had the disease helps them tremendously. So partnering them with patient navigators, to me,
Mhm.
and nurse navigate, I mean, but patient navigators to me are just so incredible. You have a partner through this, making sure there's a resource library that they can go to, partner them with patient advocacy groups so they know that they can have someone to share information, ask questions that they have, been able to get information about their disease. So the more we can empower patients on their disease, the more we can make sure that we improve health literacy, the more we can make sure that when there's a question, they can find the answer, not Dr. Google. I think, the more that they can take better control of their health and know that they deserve it. And then the last piece is even helping people think through questions to ask their physicians. I know a lot of times it can be overwhelming, and a lot of times people come to physicians and are afraid to ask those hard questions, afraid to ask. They don't want to seem they don't have the answers. They don't want to seem like they're not smart. They don't want to question their physician. But understand that as a patient, it is your health that matters. It is your life. And so demand that the physician has that conversation with you. Demand that the physician is able to break down information in the way that you can receive it. Demand that that physician takes that extra time to walk you through this. It is a lot and it is overwhelming, but it is your health, and you demand that you have all the tools, all the material, all the education you need to make the best decision jointly for you. And I cannot stress that enough. And to me, that has been another big challenge when it comes to people diagnosed. It is scary, and they feel alone sometimes and don't know and are afraid to ask those questions. But it is your health, and you deserve people taking the time to make sure you are fully aware of whatever you need to know. And I'm saying that as a physician. So,
Absolutely. I think they're, with regard to patient navigators, they're so important and they're so critical. I feel like there are never enough, and they're never included enough in the care of the patient.
yeah.
Uh, How do you, I guess, first of all, some people might not be aware of what they do. So could you just describe their role and how we can work with them a little bit more to integrate them into the treatment plan?
Yeah, I mean, number one is these people are amazing. A lot of times, particularly patients who were diagnosed, people who were diagnosed with a particular disease, um, and they've learned how to navigate it. People who are newly diagnosed, it's very hard. Again, taking a step back, being diagnosed with the C word, trying to figure out, who do I speak to, who do I believe, who do I listen to, where do I get information, where do I go, are there trials, are there medicines, am I going to live, am I going to die? There's multiple questions going through your mind all at the same time. And understand, you are not alone. There are people who've been there, who've learned how to, who understand the system, who know the best people to go to, who know where to get information. These are your patient navigators. These are people who can actually help you navigate. This becomes your buddy throughout this whole process, and then you hopefully then continue to then help other people who are newly diagnosed. But it's so important to have people who can help you navigate your disease, navigate where to get the right resources, and connect you to the right people so that you can learn how to get into the driver's seat of this and not let it define you. So I do think, and I agree with you, that they're not talked about enough. Um, I find them so valuable, and just to me, just it's almost to me altruistic. Like it are people really helping you navigate through the hardest time of your life.
I think I've read somewhere that being diagnosed with it's like you're in a country of the sick, and to have a guide through that, during this emotional time, this physically intense time, it's, it can be tremendous help practically, but, you know, equally important emotionally.
Yeah, I mean, and think about it. I mean, you have also like treatment decision regret. You have all this happening.
Mm.
It's a lot happening at once, and when you have someone in your corner who's been through it, it just doesn't change what you've been diagnosed with, but it makes it a lot easier, and it actually gives you the right resources. So I can't advocate it for it enough. And one of the things that that I would love to see more of is more patient navigators in underserved communities, and that's one of the
Right.
things that I really hope to push. How do we get more patient navigators into these underserved communities so that, again, if they have a partner to go through this, you have someone looking out for you, um, which to me is critical.
One other thing I was thinking about is the general lack of awareness. I think when people think of cancer, a lot of times they frame it as we want to beat cancer. There's not a really broad realization that it's so many different diseases and there's so many different symptoms. I know there were some amazing educational efforts that you've been a part of, such as
Mhm.
the red flag for
Mhm.
endometrial cancer. Is there where what role do you think communications and biotech and medical professionals can play in elevating awareness to watch out and to catch cancer earlier as opposed
Yeah.
to later?
Yeah. I mean, so there's a couple of things. Taking a step back again, if you think through, it's the whole healthcare to me ecosystem that we need to really do a better job in creating awareness. Um, the earlier you know, well, first of all, how about preventative care? So awareness is
Right.
critical to help with preventative care, right? And we saw the improvement in terms of cervical cancer in this country based on awareness and pathways, right? So awareness is really important, but then getting diagnosed early at an earlier stage in cancer is so important. So how do we raise the awareness? I think it's going to be all of us. That's why I said I think yes, it's it's the communication teams, it's biopharma, it's physicians, it's patient advocates. How do we together really make sure that people in their communities are aware of what symptoms to look out for? A good example is endometrial cancer. It is so hard to know, and people, when to go to a physician. And endometrial cancer, the symptoms are so vague that a lot of times it's missed and not picked up until late stage. To your point, the big initiative that we had when it comes to endometrial cancer, right? Just looking at if you're starting to spot, don't think of it as normal, especially if you're postmenopausal. Don't think of it as normal. Go to your physician. So, just little symptoms. How do we make sure that we do things in a way that people understand it? I think a lot of times we talk in such medical tech terms that,
Yes.
right, that people don't understand what we're trying to say. But again, I think bringing patients to the design lab of what you're doing is going to be important. So I mean, even in GSK, we have actually something called even protocol design lab, where we have patients coming in to really look at our protocols as well to make sure that it's applicable to patients. And I think it's the same thing with all these disease awareness, making sure you have patients at the table. And again, a diverse set of patients at the table to make sure that as we are relaying information, it's the way in which people can receive it, no matter your background. So I do think that the healthcare industry needs to hold hand. It's not about competing. It's about making sure
Right.
people are aware of particular diseases to prevent it, to catch it early, and to treat it. Um, it's going to be all of us, but it's going to be definitely in the campaign ads. It's going to be wherever you go. We should be able to get that captured so that they know. And the more people are aware, the more they can again control and get empowered to take control of their health.
And is that what you mean when I love that idea of having the diverse set of patients come in and advise in the drug development process? Is that what you mean when you describe patient-driven science and how important that is?
So we came up with a phrase, patient driven science, where patients and their needs drive the science that we deliver. And that's what that means. A lot of times you hear people say, I do this with the science, I do that with science. But in the end, sexy science means nothing if it doesn't make an impact in the lives of people. And we're in a people business. We're in the service business for people. And that is what to me, our mission is. That is our job. And so when we say patient driven science, the patient's needs to drive the science that we deliver. And one of the things, to your point, is we created patient councils. So for every tumor type that we focus on. We have a patient council, a diverse patient council that helps us from end to end, from the design of the study to your point, the awareness. How do we educate people in a way that they can receive it? What is important to them? And what side effect profile is important, what medicines are important, what outcomes are important. So these people are truly a part, these patients that actually have the disease are truly a part of the end-to-end process of drug development and drug delivery. Because in the end, we're doing it for them and with them. And that has to be a concept that we embrace. So that's what we mean by patient-driven science. And it's something that we live by. It's something that we do because in the end, it's about impacting the lives of people who actually have the disease, both the outcomes and their experience.
Yeah, you can't just take the science this far and then drop it and expect it to be adopted. It has to be communicated. It has to be co-created really with the patients in mind. And I think that's such a visionary view, and that's the way to create, better outcomes overall.
Yeah, I mean, and to me, the piece that is going to be also critical as people start doing this more is making sure that the patient councils or population that's giving them advice is truly diverse and represents the percentage of people that actually have the disease. Because what we don't want is what we call a lot of times, whether it's treatment biases or just selective biases on people who will volunteer and represent a smaller subset of people that have the disease. We need to make sure that we go out of our way to make sure the people who are giving us advice actually represent the people that actually have the disease in the perspective, in a broader perspective, so that we are actually developing the right medicines and right outcomes for those patients.
Yeah, so having more outreach to make sure we're not missing anybody.
Yep. Yeah.
How do you think we can help foster those conversations in the community more? I mean,
Yeah. So, I mean, there's a few things that we've done already, for example, at GSK, but not just GSK. I will say that across the industry, I've been doing this, like I said before, for decades. And there is a big change and shift that makes me so proud within just the healthcare system where people are finally talking about it. People are not just talking about it, but putting money behind how do we make a big difference. And again, I think when your listeners go back to what we spoke about before, when we show those numbers and show those outcomes, when you have Black people dying twice the rate of their white counterpart, and race and ethnicity being a big factor, I think our eyes are starting to open. The data that I see that came out over the last 2 years, 3 years, in terms of people really understanding and looking into the why is incredible. And not only that, I've seen the healthcare sector put a ton of money in investment in making it better. So I think that this is on the right trajectory. We need to now, to me, in terms of educating, how do we, going back to what I said before, really create these sustainable solutions within the community? How do we partner with the community? How do we make sure that we're bringing this medicine into the community? How do we make sure we bring the clinical trials, but also education into the community? How do we partner with members of the community to educate themselves? Because they have to own this. But what we have to do, let's not be, I mean, we must invest in it. So so what can we do? We did stuff, for example, we've reached out, we've done a project, for example, called Mayora, where we worked with college students to educate college students, which then educated patients. And then we actually we then looked at the educational rate from the time we started to after we educated them, and it went up tremendously. So there's ways in which to go into these communities, college students, churches, like I said, barbers, beauty shops, schools. We can go into these communities and have a big educational program to make sure they understand, and then have the community continue to educate their community. But it's going to take investment. And I'm pretty optimistic that we are ready to do that because we see these outcomes and they're not acceptable.
Yeah, see those outcomes. I love bringing the community as partners, as people who can help continue the conversation and continue the change that needs to happen, is starting to happen, but needs to get more momentum.
Yeah.
I think, feel like also there globally, I think this is a conversation in the US and perhaps globally there's more discussion that needs to happen there as well to create some changes in the trial designs and inclusion criteria
I'll
to
tell
make
you
sure.
more than discussion, and we need action. I mean, and people know me. I'm tired of we've been discussing this. I've been discussing this for the last 10 years, and there's been a lot of discussions. I mean, the good news is, like I said, we need to put our money where our mouth is. We need to invest in infrastructure, invest in education, invest in people. We have to do that. But the other piece is really let's start dissecting what can be done. Like I said, to me, when it comes to the eligibility criteria, those are tangible solutions we can change quickly. We can choose, right? It's just about choice, make
Mhm.
doing these things. And then the other pieces, when we talked about community and socioeconomic barriers, those are tangible solutions that we can actually do. And then when it comes to the overarching communication, if we all take a step back and look at our material, does it really represent the population that actually has the disease? I mean, right? And we have to be honest with ourselves. Let's revamp these things. Those are things that we can do overnight to make big differences. And they're not that costly, but yet can make a huge difference in terms of making sure people get access to innovative trials and innovative medicines. So I think we've been talking, people have been talking. Now I think we're partnering better. I think we're talking about real solutions. Now we need to action it.
I love that question that we can ask ourselves as communications professionals. Does this represent the patient That's such a clear test and something we can all do to make that change that has to happen.
Yeah. And then even languages. If we're in the US, look at the predominant languages. Can we just off the bat create material that's goes beyond English? Again, something that we can quickly do that will make a big impact. Can we make sure not only do this material look like the patients that have it and represent their culture and their community, but then from a language standpoint, can we also have a few material that it goes beyond whether it's Spanish or French? But can we do that so that we can expand the population that actually come onto our trials and understand it in depth?
Yeah, to be informed. You have the health literacy and then as well as the cultural literacy element that we can do a lot better job. And there are guidelines and there are ways to implement that.
Yeah. And then I think the other piece we can do is we commit, we set our target and we commit and hold ourselves accountable. Um, if we're going to say we're going to recruit X amount of patients for a trial, what are the pieces that's needed? And if we don't make it, we continue to recruit until we make our numbers. That's the only way I think, or we hold people accountable for what they committed to. So I think there's just a lot that we can do that's tangible. But going back to your piece in terms of comms, to me, comms is everything. Comms is the receiver, the physician, making sure the physician understands how to help this patient and also making sure the person diagnosed with the disease is very aware. And that to me sits heavily in how we communicate our study, how we communicate the disease, how active and proactive we are in making sure that we're thinking about the receiver of our materials.
And I think that's something we can do as a call to action to commit and hold ourselves accountable to this change, which is really important. I want to say thank you so much for bearing with us during the technical difficulties up front and also for sharing all your ideas on advocating for patient-driven science, addressing these disparities and closing the gap. And want to thank Black Health Now for providing this forum for us as well.
Yeah.
So
And if I could leave just with us with one thought, I mean, it is to me all of our accountabilities, right? It is all of us. And each one of us, if we're very clear on certain solutions, it is up to us to implement them. And we cannot wait for other people to do this. It is on us. We are the ones that can drive these solutions. We are the ones that can own this accountability. So one of the my call to action is let everyone be all in. Let's think about how do we make it fair? How do we make sure that we think about the receiver of our stuff? How do we make sure that we close this gap? And how do each one of us own a solution to do so?
Thank you so much.
My
I
pleasure.
very much appreciate it. And thank you. Great call to action.